Hello doctors. So welcome to the another training module in the maternal health, and in today's module we are going to talk about the two important endocrine disorders which are very common during pregnancy. So first we will talk about the hypothyroidism, and then next will be the gestational diabetes mellitus. So as you all know that hypothyroidism is a condition related to the hypofunctioning of the thyroid gland, and in this module of hypothyroidism the session objectives are to diagnose hypothyroidism in pregnancy and then how to manage hypothyroidism during pregnancy. The prevalence of hypothyroidism in pregnancy in India is approximately 4.8 to 12%. Normally what happens that during pregnancy in the first trimester, since there is a increased secretion of HCG, there is a slight increase in the free T4 concentration, because of which there can be a presentation like a hyperthyroidism, but it is a normal physiological hyperthyroidism which doesn't need to be managed, and hence that is why there is a slight increase in TSH levels during the pregnancy. How to diagnose the hypothyroidism, which is most important thing. So during the pregnancy we call it as a overt hypothyroidism whenever the TSH is more than or equal to 10 milli international units per liter and free T4 or these total T4 levels are low. While when this TSH level is less than 10 milli international units per liter with the normal levels of free T4 or a total T4 levels, then in those conditions we call it as a subclinical hypothyroidism. Why it is important to actually treat the hypothyroidism, and the reasons are that it has an effect not only on the maternal side but also on the fetal effects also. Maternal effects related to hypothyroidism are the miscarriage, repeated abortions in any lady always hypothyroidism. Then there can be a recurrent pregnancy losses, anemia, preeclampsia, even it can precipitate gestational diabetes, abruptio placenta. Even postpartum hemorrhage is the cause because of a hypothyroidism or if it is uncontrolled hypothyroidism. Similarly, there is an increased rate of cesarean sections due to fetal distress in these patients. There can be myopathy or congestive cardiac failure in the maternal effects, common maternal effects in these patients. When coming to the fetal effects of hypothyroidism, so there can be a preterm birth, there can be low birth weight babies, intrauterine growth restriction or fetal demise, there can be respiratory distress, or there is an increased perinatal mortality. Even we have seen certain birth anomalies like cretinism, which is a severe form of brain damage in which the fetus is having a cognitive, neurological and developmental impairment. Hence, it is very important to treat hypothyroidism especially during pregnancy. There are certain high risk factors for hypothyroidism. Important is the people who are living in the area which is severely iodine deficient. Then obesity is again one of the important cause or the high risk factor cause for hypothyroidism. Then any person who has undergone any type of neck surgeries are prone for the thyroid injury and hence hypothyroidism. Then there can be a goiter, or if there is any family history, especially in the sibling or to the mother or father, if there is a history of thyroid dysfunction, then their descendants are at a risk of developing hypothyroidism. So that history should be taken in these patients. And if there is any history of mental retardation in the family or in the preterm deliveries or miscarriages, then always we have to suspect the hypothyroidism in the family and that history should be taken off. Other than that, certain people who are having one of the autoimmune disorder like either a type 1 diabetes or SLE, rheumatoid arthritis, then hypothyroidism can be a part of this syndrome. Sometimes these patients have a multiply endocrine neoplasias or syndromes, in that these autoimmune disorders are also included. Similarly, if any person who is having a recurrent lady having a recurrent history of miscarriage or preterm delivery, intrauterine demise, preeclampsia, eclampsia, then always suspect hypothyroidism also. Even a subclinical hypothyroidism is responsible for these things. Similarly, history of infertility, again common cause of is hypothyroidism, which has to be evaluated in these patients. Then other than that, certain drugs like amiodarone or lithium, so if there is a prolonged use of these medicines, they affect the thyroid functions and patient may present with the hyper or hypothyroidism. So it should be suspected in these patients. Now, how to screen for hypothyroidism? So it is always recommended in all the high risk pregnant women to screen for the hypothyroidism, and we have to check for the TSH levels, which is most important. So usually during pregnancy the TSH levels are set at a different compared to the non-pregnant female or a male. So in the first trimester the reference level for the TSH is 0.1 to 2.5 international units, in the second it is 0.2 to 3, and in third it is 0.3 to 3. So it is slightly lower compared to the normal person, non-pregnant person. So this should be considered, and accordingly we have to manage these patients. So in the subclinical hypothyroidism, in the normal person usually we consider that if TSH is between 5 to 10 with normal FT4, then we consider that subclinical hypo, but in the pregnant female the TSH level we consider from 2.5 onwards as a subclinical. Similarly, for overt hypothyroidism, if the TSH level is more than 2.5 and 3, you have to suspect hypothyroidism and accordingly manage. Similarly, if TSH is more than 10 international units, irrespective of the level of thyroid hormone, this is a overt hypothyroidism and it needs immediate management. Drug of choice for the treatment is levothyroxine, which is available in various brand names. It has to be taken orally in the morning and empty stomach. This point is very important and I emphasize empty stomach, because if you eat something with this medicine then it impairs or hampers the absorption of levothyroxine, and because of which you won't get an adequate effect of the dosage which you are giving. So at least patient should be empty stomach for next 45 to 1 hour. So empty stomach early in the morning this drug should be taken. This belongs to a category A drug, which means that it is safe in pregnancy and during lactation. So there is no harm in using this levothyroxine. It is not going to affect the fetus, rather it will be helpful. So many times patients ask you this question whether this is safe or not. Yeah, it is safe. So you very well recommend this medicine to these patients. Then treatment plan is like that: if TSH is less than 2.5 in the first trimester, and if it is less than 3, then in the second and third trimester, then usually it doesn't need any treatment. But if TSH level is between 2.5 to 10, it is a subclinical hypothyroidism, and such patients, such pregnant females actually need the 25 microgram of levothyroxine per day, again empty stomach. If TSH is more than 10, then it is actually overt hypothyroidism, frank hypothyroidism, and in such patients we have to start 50 microgram of levothyroxine per day. If initial TSH is less than 10, treatment to be stopped after delivery, but if initial TSH is more than 10, then usually in these pregnant female, even after delivery, we have to continue with the levothyroxine with the monitoring of the TSH levels. Important is that if a pregnant woman who is already hypothyroid before pregnancy, she has to continue her treatment during a pregnancy with the same target range. And as I told you, this is a category A, means safe in the pregnancy and lactation, and in pregnancy, even in all the trimester, this is the safest drug, so it can be continued. They are not supposed to stop the medicine, otherwise they may lose their conception. So it is very important. For the monitoring purpose, usually you have to monitor them in every 6 weeks with the TSH level. So this is most important. In a non-pregnant females, usually so frequent monitoring is not required, but in female patient, every 6 weeks we have to monitor the TSH level and accordingly adjust the dosage of the levothyroxine. Then if a TSH level goes less than 0.1, then we have to avoid such levels, and to do so we have to decrease the dose by repeated monitoring of the TSH level. After delivery dose either it can be need to be decreased depending upon the TSH level, and that only guides us that whether we have to decrease or increase the dose, and in every 6 months we can monitor these patients after delivery for the TSH level. So frequent TSH monitoring after delivery is not required as during the pregnancy, which is 6 weeks. After delivery, it can be 6 months. If any patient who misses the doses on some day, then as soon as he or she remembers that he has to take the medicine, then immediately they should take their dosage. But in any case, if they miss the whole day, then the next day they should take their double dose, so that the TSH level, the thyroid hormone level should be maintained adequately. So this is all about hypothyroidism management during pregnancy. Now next we are coming to our next talk, that is the gestational diabetes mellitus, how to diagnose and how to manage this condition. So again, it is very important condition, gestational diabetes mellitus, and as we know that diabetes mellitus incidence and prevalence is rapidly increasing, and by 2045 it has been expected that almost 1/3 population may be having the diabetes mellitus. So we should be very alert about this condition, and gestational diabetes mellitus is one of the important risk factor for the future type 2 diabetes mellitus in these females. So they should be diagnosed early so that we can prevent various maternal and fetal mortality in these patients. So the session objectives of this GDM is that you have to diagnose the gestational diabetes, then second important, how to manage it with the medical nutritional therapy and exercise, and at the same time we have to learn, if it is not controlled with medical nutritional therapy, then how to do a medical management in these patients. So by definition, diabetes mellitus is a metabolic disorder as a consequence of either decrease in insulin secretion or increase in insulin resistance, or both. So whenever such stage comes, then the patient presents with hyperglycemia, which we call it as a diabetes mellitus. Now diabetes in pregnancies have got two categories. Either the pregnant female is having a diabetes before the conception, that is pre-gestational diabetes. She might be suffering from either type 1 diabetes or type 2 diabetes, or if the diabetes is diagnosed for the first time at the pregnancy, then we call it as a gestational diabetes mellitus. So both the situations may be. In India, the prevalence of gestational diabetes. Now, when we talk about the epidemiology of diabetes mellitus, so it has been observed that 1 in every 10 pregnancies are actually associated with diabetes, and we look into detail, then 90% of them are actually a GDM. When we consider about the prevalence in India, then it is approximately 10 to 14% of cases of GDM. So as I told before, what is GDM? So it is any degree of carbohydrate intolerance, which can be either a simple impaired fasting glucose or impaired glucose tolerance, or frank diabetes, which is diagnosed or actually detected for the first time during pregnancy, then it is known as a gestational diabetes mellitus. So in India, when we look into the ethnicity, so usually what is observed that there is a 11 times increased risk of glucose intolerance in the Indian women compared to the Western population, and India actually is highest frequency of GDM compared in the South Asian countries. So this indicates that we should be very alert in diagnosing diabetes during pregnancy in these females. Coming to what is the actual etiology of diabetes mellitus during pregnancy or at the time of pregnancy, which we call it as a gestational diabetes. So usually this can be inherited. It means that there can be a family history of diabetes in the lady, or there can be a certain intrauterine environment which may be responsible for hyperglycemia in these patients, but exact cause is still not known, but there is one or the other. So as this slide shows you that during pregnancy, after 28th week of pregnancy, usually there is a rapid increase in the gestational hormones, that is the estrogen, progesterone and HPL, and because of that there is, as these are the hormones which increases the glucose levels in the body, so simultaneously there is an increase in the insulin level to cover up that, to control that glucose levels, and in that way it normalizes the glucose level, and after pregnancy, after delivery, usually these hormones subsides, and in that way these normal hormone changes during pregnancy settle down the metabolic state of the body. In this slide, as you see that in a normal non-pregnant female, usually balance is there between the insulin secretion and insulin resistance, and this is how the blood glucose is maintained as shown in a blue line. What happens during a pregnancy? During pregnancy, there is an increase in insulin resistance as shown by your oval egg of red color. So, to compensate this resistance, there is a compensatory increase in insulin secretion, and this is how this balance is maintained, and there is no hyperglycemia in a normal pregnancy. But in gestational diabetes mellitus, what happens when the insulin resistance is increased, the compensation by insulin secretion and lack of diabetes. Important of if the obesity, that is BMI, is more than 30 kg per square meter. Second important is if there is pregnancy or diabetes, then usually it is a risk factor for GDM. Then there can be increased maternal age is again one of the important cause. Similarly, if a female is suffering from PCOD, again there is a risk, or there is a use of steroids, or there can be other metabolic syndrome, then they are prone for GDM. Similarly, there are certain pregnancy factors like multiple pregnancies, twin pregnancies, usually predisposed for GDM. Similarly, if there is a previous history of GDM, there is a high risk of developing the GDM in the next pregnancy. Polyhydramnios and persistent glucosuria, all these are the risk factors for the gestational diabetes. So, we have to observe, and if any such high risk factor pregnancy is report to your clinic, you should be alert for the gestational diabetes and take proper care of these patients. Now, which screening test for the gestational diabetes? Again, it is very hard. There are multiple societies which have given a certain guidelines for the diagnosis of gestational diabetes, but the various simplest way to diagnose is the guideline given by DIPSI, that is the Diabetes in Pregnancy Group of India, and it is very simple, in which you don't need to have a patient to come fasting to your clinic. So, if at whatever time the patient or the pregnant lady is visiting to your clinic, you can do this simple test, and this simple test is a single step test in which you have to give that lady to consume 75 gram of oral glucose, and you have to measure the plasma glucose 2 hours after the ingestion of 75 grams of oral glucose. So, how it is given? So, this 75 gram of glucose is dissolved in a 300 ml of water, and the lady is asked to drink that water in minimum 5 minutes, irrespective whether the patient is empty stomach or whether he or she has taken a food. So, it is very important for this test. And then the plasma standardized glucometer to be used to evaluate the glucose meter, and we all know that the standardized glucometer are available in all our centers. So, if the 2-hour postprandial glucose, that is 2 hours after the ingestion of 75 grams of glucose, if the blood glucose levels are less than or equal to 120 milligram per deciliter, then this test should be repeated every 2 weeks in second trimester and every week in the third trimester. But in case if this glucose level is more than or equal to 120 milligram per deciliter, then this is the lady who is prone for or is having some sort of glucose intolerance, and this is a patient which should be immediately put on medical management or nutritional management of the diabetes mellitus, so that this can be controlled. Blood glucose of this pregnant female can be controlled. During the test, if any patient who ingest and then vomit out within the 30 minutes of glucose intake, then this test needs to be repeated on the next day. But if the vomiting has occurred after 30 minutes, then we can continue the test, because it has been observed that there is a complete absorption within 30 minutes after ingestion. So, it is very good. And we always remember that 120 milligram per deciliter of plasma glucose is the cutoff for the diagnosis of GDM. If a patient is having 121, it means that this is gestational diabetes. You are dealing with gestational diabetes, and immediate medical nutrition therapy should be started in these patients. Now, timing of the testing is universally it has been considered that all pregnant women should be tested for GDM twice during their pregnancy period. But first testing in these patients should be done at their first visit at the ANC clinic. That visit may be in the first trimester or second trimester. So, at the earliest, first test should be done. If that test is normal, then it should be repeated at 24 to 28 weeks of pregnancy. But if initial test is positive, then we have to start immediately management. As per diagnosis, gestational diabetes mellitus is labeled when the patient is positive between 24 to 28 weeks. So, in the past, usually the first test was recommended between 24 to 28, but now the guidelines has been changed. First and foremost is at the first contact, the patient should be tested for the blood glucose levels using a 75 grams of glucose, and if it is normal, then the second test to be repeated at 24 to 28 weeks. So, this is very important. And between these two tests, if first test is positive, the first test you did in the first trimester, in the last week like 16th week or 17th week, then the second test at least there should be a gap of 4 weeks that has to be taken care of. Now, even if a patient presents beyond 28 weeks for the first time to the NC clinic, again at the first point of contact, please test for the blood glucose using a 75 grams of glucose in these patients, which is most important. So, it has to be conducted in all the pregnant females at first contact, irrespective of the trimester in which they are coming in contact with the health worker. Now, there are certain maternal complications GDM which we should be aware of, because of which it is very essential to manage this condition. These complications are polyhydramnios, preeclampsia, prolonged labor, obstructed labor, uterine atony, postpartum hemorrhage and purpura infections. So, these are the very common important maternal complications which are responsible for the various maternal morbidity and mortality, and if we want to control the maternal mortality, then it is very important to diagnose this condition, so then we can prevent these complications related to GDM in these patients. Similarly, the fetal complications which are related or which are common in the patients with GDM are the spontaneous abortions, congenital malformations, intrauterine death, sepsis, stillbirth, shoulder dystocias, birth injuries, neonatal hypoglycemia and then respiratory distress syndrome. So, these are the very common fetal complications which are responsible for the fetal death. So, we have to prevent this, and this can be simply prevented by managing a plasma glucose of the pregnant female. Now, coming to the management approach in the patients with GDM. So, what is important is that it is not a fixed, like for malaria or for dengue or for any other disease, we have a fixed plan of treatment, like if patient comes, you have to give this much dose of chloroquine. So, it is not fixed here. You have to actually customize the treatment. You have to individualize the treatment plans, which is most important and which is convenient for the patient. Because as soon as you declare to the lady that she is suffering from the diabetes and it is going to affect her health as well as her baby's health, then they are actually suddenly goes into depression. And when if you advise any management, then it is very difficult for them to conceive. So, gradually console them and then let them know that this is very easily controllable disease and you can control it very easily by simple steps. So, this is very important, and when you individualize these, it is a combination of few therapies. First and foremost is that the regular glucose monitoring is must in these patients. Following glucose monitoring, the second important step is the medical nutritional therapy in these patients along with exercise and psychological support. And psychological support, I am again repeating, because whenever you actually disclose this thing that there is some problem in the metabolic state of any pregnant female, then she is immediately go into a sort of depression. So, psychological support of the family as well as of the health staff is most important. When I telling medical nutritional therapy, so this is important because you have to take a very important decisions about the nutrition of these patients, because they are having a baby in their womb and you have to take care of the nutrition of both of them. So we call it as a medical nutrition, so that in spite of restricting few things, it is important that all nutrition should be supplied to this lady, and along with that a slight form of exercise should be continued, so that it can take rid of insulin resistance in these patients. The next step comes the pharmacotherapy. So role of pharmacotherapy is at the end in these patients. First and foremost is the nutritional therapy, then exercise plus psychological support. All these three usually control the hyperglycemia in most of the patients, and few of them needs the pharmacotherapy. And if it is not controlled at the level of the PHC level, then early referral of these patients is always indicated, and early referral will help to prevent the complications in these patients. So medical nutritional therapy exercise, as I told you, is the mainstay of these patients, and those who have diagnosed with the pregnant women who are diagnosed with the GDM, usually we wait for the results of medical nutrition therapy and exercise for at least 2 weeks, and we repeat the blood glucose levels after 2 weeks, the same oral glucose tolerance. And if it is well controlled after medical nutrition therapy, then that should be continued. But in the female, if it is not controlled, then usually we have to go for the pharmacotherapy in these patients. And the medical officers who are posted at PSC, they can easily start or initiate these treatment. But the pregnant females who are having a blood glucose level still on a higher side, or who are if on insulin therapy and their blood glucose are not under control, then they should be early referred to the district hospitals or to the medical college, so that that can be controlled adequately. At the district hospital or medical college level, there is a teamwork which involves the specialists. There can be gynecologists, physicians, medical officers. They can start the treatment, which can include the metformin or insulin, or a combination of metformin and insulin. And in that way, the postprandial hyperglycemia can be easily controlled, and usually approximately 1 unit of insulin is required to control a 30 milligram of dextrose. So if whenever there is increase of a blood glucose from the normal level, accordingly the insulin dosage can be given. Metformin, the important point about metformin is that it should not be given in the first trimester. It can be started after 20 weeks of gestation, usually in the dosage of 500 milligram twice a day, and maximum dose is 2 grams, but only after 20 weeks, not before that. So always keep in mind. So at a first contact in the first trimester, if there is, you diagnose a patient having a hyperglycemia, then you better go with the insulin rather than the, and these medicines should be given after medical nutrition therapy and exercise. But if a blood glucose are very high at the first contact, then you cannot wait for the 2 weeks for the effect of medical nutrition therapy and exercise. You have to start pharmacotherapy along with nutrition therapy and exercise at the same time. So that should be initiated at the earliest. So this should be kept in mind in all these patients. Now regarding the insulin, so it can be started at any time because it is the safe drug which can be given in female patients, and usually the preferred drug is the Mixtard, which is a combination of glucose monitoring which you are doing regularly in these patients. So as this slide shows, and for the glucose monitoring, usually as per the recommendations, at least 6 readings are required, which are fasting, post breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner. But it is very hard to do these tests daily in these patients. So what is ideal is that check the blood glucose and accordingly adjust the doses, because in that way you know that which dose should be increased and at what time. So depending, if fasting is high, you have to adjust the evening dose. If the lunch, pre-lunch or post-lunch is high, then you have to adjust your morning dose. So accordingly you can adjust the insulin dosage in these patients. Then this should be done. Again, I told you that there is no fixed rule for the glucose monitoring. So again, depending, even sometimes after starting insulin therapy, some patients there is a fear of hypoglycemia, and that is an important inertia cause for the physician as well as for the patient to start insulin therapy. It can be done in 2-3 days once it is controlled. The second, whenever they feel a hypoglycemic symptoms, they should test their blood glucose so that it can guide them whether they are actually having hypoglycemia or it is just some other reason that they were not feeling unwell. So that is most important thing that should be monitored. Other than that, to prevent the hypoglycemia risk, always ask your patients to always keep a sugar or a glucose powder ready at their home, so that if they have such feeling, then they can drink those drinks, and which can help to prevent the severe hypoglycemia in these patients. Then usually early referral, as we talked about it, so when it should be early referred. So if the patient is having a nausea, vomiting along with GDM and is not able to tolerate anything, then better refer to higher center so that it can be adequately managed. If at the first visit, if the blood glucose level is more than 200 milligram per deciliter, with or even without insulin, immediately refer such patients to higher center so that they can be adequately managed. Similarly, if the total dose of insulin required for the management of GDM is more than 20 units, refer this patient, because this patient needs complete workup to find out any other cause for hyperglycemia in these patients. And if patients develop recurrent hypoglycemia, again needs referral for the higher center so that it can be managed properly. Or if a patient is not satisfied that pregnant women is not ready to follow the management guidelines, then again refer it so that he can be taken care by a team of doctors. Then the obstetric care which is needed for the pregnant women during GDM is again very important. So at the level of PSC, because you are available, so a proper antenatal care should be provided by the gynecologist or the trained doctor available. Even after 20 weeks, a fetal anatomical survey is mandatory in these patients, and if you find if any fetal abnormalities, then accordingly it can be taken care of. Similarly, the routine antenatal care of these patients is very important because these patients are prone for preeclampsia and eclampsia. So, routine blood glucose checkup, urine microscopy, urine test for albumin is must in these patients, so as at the earliest we can pick up the eclampsia or preeclampsia. And at the same time, you have to also monitor for the uncontrolled blood glucose. If it is there, then immediately you have to refer such patients to the higher centers. Similarly, monitoring of the fetal growth is must, which can be done by a routine antenatal visits and with the auscultation, as well as time to time scanning of the fetus is very important in these patients. And as I told you, the monitoring of the hypertension, proteinuria and other obstetric complications like polyhydramnios or all these conditions, if it is developing, they need referral to the higher centers. Then the pregnant female who is diagnosed with gestational diabetes may require early delivery. Then if this is required in these patients because of the associated other complications, then it is very important that the lungs of the fetus should be mature. So then dexamethasone should be given in these patients under the supervision of obstetrician. That is most important, and they need to be admitted in the hospital with a vigilant monitoring of the blood glucose, which is must in these patients, because if there is any high or low levels and not able to manage it, they can be actually referred to the higher centers. Then insulin therapy in the uncontrolled patients, if the insulin is, you are giving 20 units of insulin per day, still it is not controlled, then these patients may go into preterm labor, and such patients need a planned delivery and hence should be referred to a higher centers. The patients, pregnant females who are actually well controlled and have a well controlled diabetes mellitus during pregnancy, usually they don't need to be delivered early, but we can wait for the spontaneous delivery, and induction of labor can be started after the 39 weeks of pregnancy. But if there is a poor plasma control, there is a risk of maternal as well as fetal morbidity and even mortality, and then such patients needs early delivery, needs a supervision of our experts, and in such cases it is better to be referred to a higher center. Then vaginal delivery is usually preferred if it is well controlled, but LSCS may be planned in these patients because most of the time these patients are having a macrosomic babies. So to avoid any injury to the vagina, LSCS can be planned. So to considering the fetal macrosomia, usually we prefer the cesarean sections in these patients. And usually the patients who are on metformin or insulin require regular monitoring, as I told you, by glucometer. And on the day of the delivery or cesarean section, both the medicines can be stopped so that we can prevent the post-delivery hypoglycemia in these patients, which is most important thing. And then their nutrition can be maintained, their hydration can be maintained using a normal saline. And if they develop hypoglycemia, then you can give a dextrose normal saline in these patients. Then again, the neonate should be taken care by the medical officers, which is most important thing. And there is a risk of hypoglycemia in these patients in neonates, so that should be taken care of. So immediate feeding should be started in these neonates to prevent hypoglycemia, and we should start monitoring them for their blood glucose levels, and accordingly you have to give either the glucose water to them or a dextrose drip depending upon the level of blood glucose, which is most important. Other than that, neonates should be monitored for the respiratory distress, convulsions or hyperbilirubinemia, which are common complications in these babies delivered from a pregnant female with hyperglycemia. So it should be taken care of. Now, post-delivery follow-up of these GDM is most important, because I told you that GDM is the most important risk factor for developing type 2 diabetes mellitus in the future. So they come under the NCD program also. So you have to closely monitor them, and they should be monitored in every 6 weeks with the 75 grams of OGTT, whether they are still having a glucose intolerance or not, and accordingly they have to be managed. And after delivery also, these patients should be advised lifestyle modifications, weight control, which is most important, as well as exercise, and nutritional therapy should be continued so that the rapid weight gain or obesity can be avoided in these patients, and they should be registered in the NCD clinics, and where they can be regularly monitored for the hypertension as well as diabetes mellitus and counseled regularly for their behavior. So in summary, we can say that diabetes is a complicating factor in pregnancy, and universal screening is must in these patients, which is the most important reason. And then effective glycemic management will help in the control of the medical morbidity, mortality, as well as fetal morbidity and mortality in these patients. And insulin is the safest drug to be used during pregnancy, irrespective of any trimester. So don't hesitate to use the insulin in a small doses, as prescribed that 1 unit is sufficient for the 30 milligram per deciliter increase in glucose. So start it, and counseling of the patient is must, so that they should not be fear of an injection or the insulin therapy, but it is good for their baby also. So that should be counseled regularly in these patients. So details are also available at the NHM site about this. So in that way, it ends now. This module finish. Thank you very much.